Well, practically at the end of a previous recording, we came to a point where we talked briefly about the composition of blood and formation of foreign blood elements, but the emphasis was mostly placed on the red blood cells, their lifespan, and also the recycling of a hemoglobin, but iron ions in particular, in a process of maintaining the body homeostasis. We also indicated that white blood cells are present in significantly smaller, lower numbers per microliter of blood. Only between 5 to 10,000 white blood cells or leukocytes are expected to be found within the blood of a healthy adult average person. Although we simply count them as white blood cells, we know that there are 5 different subtypes of blood cells that are leukocytes. 3 of them fit into the description of granular, and there are eosinophil, basophil, and neutrophil. But we also have agranular white blood cells. They're called lymphocytes and monocytes. Occasionally, when we need a little bit more precise diagnostics, we would like to see the differential white blood cell count. And it is done in order to try to determine what is the reason for altered number of white blood cells per sample. So if we have an increased number of white blood cells, we have a good reason to suspect that there is some kind of inflammatory process. If their numbers are reduced, we also want to find out what is going on. So differential count of white blood cells would be able to identify a little bit more precisely what is going on. So for example, the neutrophils that are most abundant types of white blood cells, their high count indicate most likely bacterial infection, but also could be encountered when having a patient with burns, inflammatory changes of different kind, or simply under an exorbitant amount of stress. However, the low number of neutrophils could be very directly pointing to exposure to ionizing radiation, consumption of certain prescription or non-prescription drugs, which could have certain toxicity, deficiency of B12 vitamin, or some other systemic diseases such as lupus erythematosus, the lupus better known to commons. Eosinophils, their numbers go up when a person is suffering from certain allergic reactions, but also it could be to parasitic infestation, but their numbers also could be related to a certain number of autoimmune disorders. Decreased number of eosinophil white blood cells could be seen because of drug toxicity. Finally, the basophils, their numbers also would go up during allergic reactions, but in a variety of different leukemias, malignant diseases, and even in a case of hypothyroidism, when the thyroid gland is functioning less than it should be doing. For the lymphocytes, their numbers are likely to go up with viral infections, but also it could be a very ominous sign of certain types of leukemia, where there are reduced numbers, lower number, might be indicative of prolonged disease or some drugs which have immunosuppressing effects, such as cortisol being consumed or taken over extended period of time. Finally, the monocytes could be increased in their numbers with viral, but also with fungal infection, tuberculosis, leukemias, or some other form of chronic diseases. Reduced numbers of monocytes if the bone marrow is suppressed, or if some kind of drugs that are having immunosuppressant effectiveness are consumed over a prolonged period of time. So very clearly, this is kind of variety population, and as such, certainly deserves a little bit of a different attention not only to be described as quickly as we did with erythrocytes. So one of the things that we have to consider right away is, how is it possible then that white blood cells are essential part of our immune system, and where this ability actually comes from? Normally, most of the white blood cells, being part of full blood, will be just passing through the cardiovascular system. However, if there are some local signs of infection or inflammation, a certain set of changes will start happening. The endothelial cells in the vicinity of infected or inflamed part of the body will start exhibiting proteins on their surface oriented towards the lumen of blood vessel. These proteins are going to attach to the carbohydrate groups that are part of cytoplasmic membrane of white blood cells, slowing them down, practically increasing, let's say, friction between the white blood cell and the wall of this blood vessel, until those green colored boxes are also proteins that are called integrins, and they form a bit better and more lasting bond between endothelial cells and white blood cells. This is the neutrophil, typical cell that's going to be the first one to emerge from blood vessels and to start penetrating into infected area. So at that point, when a short-lasting contact is established, white blood cell starts rolling upon itself along the wall of a blood vessel, and it is looking to find an opening, a little tiny gap between these two endothelial cells, through which white blood cell will be able to squeeze through and start moving in the direction of tissue which has been affected by inflammatory change. This type of attraction that white blood cells have is called a chemotaxis, that they are able to respond to certain chemical factors that are released at the inflammatory site. So that is the chemotaxis, and their ability to pass through the intact wall of a blood vessel is known as the diapedesis. Moment they pass out into tissue, they're going to have a strong phagocytic activity, where they will try to engulf any kind of foreign particles, whether they're microorganisms or some other form of cellular debris, and their numbers during the inflammatory process locally is going to start increasing. Of course, some of them will not be able to conquer the area and to win the immune battle. They would become victims of this kind of ongoing inflammatory battle, and practically the neutrophil cells are those ones that would be mostly contributing to formation of pus. It's really like a consequence of this kind of strong inflammatory response which is happening, while in the meantime remaining surviving neutrophil cells are simply surrounding the area and preventing any further movement of pus deeper into tissue, but most likely pushing it more superficially until it doesn't make opening and the pus naturally drains itself out of the body itself. So that explains, at least in a basic principle, like what kind of assistance white blood cells going to provide for immune system during any type of typical, or let's say even slightly atypical, inflammatory episode. Once we are done with the white blood cells, we're going to take a look at platelets, the thrombocytes. As we know, there are fragments of cells coming from their predecessor cell, megakaryocyte. And as such, they should be present within 150 to 400,000 per microliter of blood. That is the normal count. And of course, why do we call them platelets is, I'll be honest, unknown to me, because they don't look to me like little plates. but they are thrombocytes, and they do have a very significant role, because without thrombocytes, basically the blood coagulation, blood clotting, would have to be reinvented and would have to use some different form of physiology and its principles. So what's happening, and why do we have this diagram in place? We know that it's quite common that blood vessels suffer some form of minor damage. It's usually some kind of tiny nick, but it's sufficient enough to cut open a smaller caliber blood vessels through which blood's going to start leaking out, and we would recognize it right away as some form of tissue damage. Normally, we're thinking, okay, let's find a Band-Aid, let's put it over the surface of a wound, the bleeding will stop, the scab will form. A couple of days later, everything is going to look all right, the wound would heal, and life continues as beautiful as ever before. In order to have this kind of happy end, basically we have to recognize what's happening at this level. What are events that would lead to moment when the bleeding becomes controlled until it becomes fully stopped. So this is a three-step process, so to say. Here we have on the diagram one, a minor area of minor blood vessel being damaged. Certainly, a damage definitely exposes some kind of structure, just as we would damage the walls in our houses. It would immediately show some gaps, it would show some framing, or anything else that is holding the drywall in place. So we would see the structure behind the wall. And that is why the collagen fibers and damaged endothelial cells within a blood vessel are those ones that immediately trigger attention of locally present thrombocytes. But before that would happen, there is another important event that also takes place. Local areas, smooth muscle fibers, produce their first and most significant response, which is a vascular spasm. The vascular spasm simply aims to reduce the blood flow through damaged area, because if we're to form a platelet plug that is going to completely block and stop further bleeding, any kind of excessive blood flow or increased blood pressure could simply wash the platelet plug away, and the bleeding will continue, becoming practically the endless story. So the vascular spasm is the first response that we have to observe on our vessels. Vascular spasm, as it reduces and slows down the blood flow through the damaged vessel, practically makes it possible that slower moving platelets are now making the contact with exposed collagen fibers, with exposed damaged cells. And as a result of this, their surface becomes sticky, and they start adhering not only to the margins of a defect, but also become sticky so that new thrombocytes are just adding themselves onto the surface of those ones which were previously trapped in this area. So first is platelet adhesion. That is what we're talking about, that kind of stickiness of the thrombocytes. Another thing that we need to add here, that thrombocytes, regardless of their minute size, are having pretty much potent chemicals that are stored in a variety of different vesicles. One of them is the platelet-derived growth factor, basically a hormone, that'll start helping us with repair, with the proliferation of these endothelial cells when the defect is fully controlled and when it's time to go through full repair. Also, they have some adenosine diphosphate, adenosine triphosphate, serotonin, thromboxane A2, all contributing to additional stickiness of thrombocytes, and also, as you can see here, their shape changes from what they were illustrated as on the diagram number 1 in a small oval form. Now they become some kind of multi-angled structures with plenty of projections coming from their outer surface. And those projections actually enable platelets to make very significantly more contacts with additional thrombocytes in the area. So that is what platelet adhesion leads to. And it is practically from just introducing the adhesiveness, now we're observing the platelet aggregation. Platelet aggregation must be followed with formation of platelet plug. Again, assuming that conditions are properly met, that the vascular spasm is still present, and it will be present from a couple of seconds to a couple of minutes for as long as it lasts. And as a result of formation of platelet plug, we're going to practically observe the moment where the bleeding has been controlled. Certainly, this is just step 1. Step 2 would be to introduce the formation of blood clot in the area, and of course, later on, complete repair. So blood clotting or blood coagulation is something that must include red blood cells as well as protein called the fibrin. As we can see on this photomicrograph, the fibrin creates a little bit of a net, trapping red blood cells, making sure that platelets of this size are now having a very significant physical support of red blood cells that will definitely contribute to stability of a coagulum and will make sure that with its proper adhesion force, time needed for tissue repair is given. So we can now proceed to analyze and to say a few words about what leads really to formation of a blood clot or blood coagulum. Firstly, we have to identify 13 different so-called factors of coagulation. They're marked with the Roman numerals, and it goes 1 to 13. Certainly the numbers do not show anything about more or less important, but rather numbers are given as they were discovered. So for their proper synthesis, of course, most of them would come anyway from liver, and it is the vitamin 4, which becomes particularly important for proper synthesis of coagulation factors number 2, number 7, number 9, and number 10. So in order to understand this, because the diagram itself might be a little bit complex, not all the coagulation factors have been introduced and included into this diagram. The emphasis is to understand that we have 2 possible mechanisms that are leading into coagulation of blood. One is called the extrinsic pathway. Extrinsic simply means that there is a factor external to blood vessel that will trigger cascading events, multiple chemical reactions, resulting in a formation of blood clot. So reason is external. Most likely and most typical and easiest to understand is that we're talking about tissue trauma of any kind. Tissue trauma, of course, has to include some blood vessels that would start actively bleeding, and this is where blood coagulum would be formed. Other possible way of seeing blood coagulating is much slower than when it happens through extrinsic pathway. Intrinsic pathway could lead to coagulation of blood, but events leading to blood clot formation could last for hours. What's going on is that we do not have anything else other than internal to blood vessel reason for blood to start getting coagulated. And in this case, you can see that we're having some damage internally done to endothelium. Now, don't get confused. It's not a tissue trauma. It is just disruption of the normal, regular build of blood vessels. Let's say formation of some kind of atherosclerotic plaque, which heavily disrupts the normal composition of the endothelium, making it quite bumpy, making it quite irregular, making it obstructing the blood flow, creating a turbulent blood flow as the blood passes over the atherosclerotically changed area. That is intrinsic event that eventually would lead to blood coagulation. So let's go first and explore the extrinsic pathway. And we're going to stop at the level of prothrombinase, because at that point, both extrinsic and intrinsic pathway, more or less we can say, do have the same common finish line. For extrinsic pathway, we're talking about release of so-called the tissue factor, which is also known as the thromboplastin. And a thromboplastin is the first of the needed chemistry that we have to use in order to reach the stage where the blood is going to start coagulating. So, tissue factor or thromboplastin. In the presence of calcium ions that are identified, basically we're going to see the thromboplastin leading to activation of factor of coagulation number 10. That's not an X, it's a 10. This is not a V, it's Latin numeral 5. So activated coagulation factor 10 with presence of calcium actually activates in coagulation factor 5 and lead to formation of prothrombinase. At this level, both intrinsic and extrinsic pathways become common. For the intrinsic pathway, it is a little bit more kind of complex because it involves activated factor number 12. Again, with the presence of calcium ions, leads to activation of factor number 10, and also activated platelets and platelet phospholipids are contributing to activation of factor 10. It combines with a coagulation factor 5, presence of calcium, and here we are at the appearance of prothrombinase. From this point on, there is no extrinsic or intrinsic pathway, it's just a common pathway. Prothrombinase, obviously with the ASE ending, is an enzyme which converts prothrombin, that is coagulation factor 2, with the help of calcium ion, into thrombin, that is active protein. And as seen on a previous picture, this is our ultimate goal. We still need to reach the level where fibrin has been created, and fibrin that starts trapping red blood cells. It is going to happen in the third and lowest part of this diagram, where the thrombin is activating coagulation factor number 1, which is called the fibrinogen. And when it's activated, basically it turns into fibrin. Otherwise, without this conversion of fibrinogen to fibrin, loose fibrin could be very dangerous to our own vessels, so we have to keep it available, but in its inactive form, only proper activation will lead to proper conclusion of this coagulation cascade. Factor number 13, which is also introduced onto this diagram, is something that we need in order to strengthen the fibrin threads. And as such, the full quality coagulum has been formed. We know that with the formation of coagulum, there would be no signs of active bleeding any longer, and presence of different type of cells under the clot, like fibroblasts or any other cells that are capable of repairing the damage, would lead to gradual, slow separation of clot and dissolving of fibrin, which result only when we have complete tissue repair and it becomes safe to remove the clot. Another thing that we need to briefly talk about is that the blood, although it shows just one type of red blood cell shape-wise, essentially is something that when we explore through the world, we find out that we are not absolutely having identical composition of blood. And that is what was discovered quite some time ago, almost 200 years ago, that amongst humans, we have four main well-known blood types. They are type A, type B, type AB, and type O, but it would be more accurate to say type 0 than just type O. So what makes these four blood types being different? On the presence of their erythrocytes, presence or absence of different antigens is determining what kind of blood type such a person is. Obviously, to be blood type A, all the red blood cells of that person will have on their surface antigen A exposed. For people who are blood type B, of course, they would have a different antigen, and that's going to be the antigen B exposed on the surface of all red blood cells. A rare blood type AB would have both antigens A and antigens B on the surface of red blood cells, but type O, 0, would have no antigens. Neither A or B would be seen on the surface of these red blood cells. That's why I think it's kind of better to say 0 than O. O must be misleading to another non-existing type of antigen. So that is what we see on the surface of red blood cells. And what's going to happen in the plasma of these four different blood types will look a little different. So plasma, as we know, is a liquid component of blood containing lots of proteins, some of them being globulins or gamma globulins, and they are having a role of antibodies. So here we are. If a person is blood type A, it doesn't make sense that the plasma of that person's blood would have antibody against the antigen A. It'll have to be against the other antigen, antigen B. So plasma has anti-B antibody for a person whose blood type is A. A person having blood type B, again, would have to have the antibody against the other major antigen. Therefore, it's going to be anti-A antibody found within the plasma of a person who is blood type B. Person being blood type AB makes no sense to have antibodies against both or either of the antigens its own red blood cells exhibit on the surface. So plasma of person type blood type AB has no antibodies anti-A or anti-B. Finally, for blood type O or 0, plasma would be with both anti-A and anti-B antibodies. And on the basis of this very simplified viewing of four major blood types, basically we know this is what generated the idea that blood type O or 0 could be seen as the universal donor of blood, and the blood type AB could be observed as the universal recipient on the basis of these A-B antigens. At this time, it is also important to say that our red blood cells do not have just antigen A or B or both or none. There will be quite a few more C, D, and E group of antigens, then Duffy, Damrock, Kelly. Number of them have been discovered. However, the most dominant are A and B antigens. And that's why in a regular process, which involves blood transfusion, we're trying to match the donor and recipient to have major blood compatibility, blood type A donor, blood type A recipient. But in the case of dire straits, we can still opt for universal donor and universal recipient for blood types O and AB. But as I mentioned, there are a group of antigens C, D, E, and antigen D is quite interesting for us. It has been discovered a long time ago, not only in humans, but also on certain species of rhesus monkeys. Hence, it was given the name, which is rhesus factor or RH factor. But we also call it its proper name, which is antigen D. It's a very strong antigen. However, its distribution worldwide is about 85% of people are having antigen D on the surface of their red blood cells, and 15% of people don't have it. So certainly, people who have antigen D, let's go to previous diagram. Let's say one of these purple bubbles is antigen D. Makes no sense to have anti-D antibody because it would be counterproductive. We don't want our own immune system to start killing our own red blood cells. So having antigen D or being Rh positive blood type is very common. As I said, about 85% of people in the world are Rh positive. 15% who are Rh negative could be point of interest for us. Because normally, during our lifetime, we do not expect our blood to get mixed with somebody else's blood. But there are moments when it happens. For example, in a case of some kind of emergency, we might be receiving transfusion of blood coming from a different person. And also, another important thing which this diagram very directly points out, it's the pregnancy. It's a dominant mode of inheritance to inherit the D antigen. So if either of two parents are D positive or Rh positive, their common child would definitely be Rh positive, whatever blood type. So if mom is Rh positive and she donated or gave a gene, so her child growing in her fetus is also Rh positive, we don't have any kind of problematic situation. We have a situation which involves, and it's only one possibility as illustrated, that mom is Rh negative and her child is Rh positive. Fetal antibodies are small enough and they would be crossing through placenta. It is something that we have to accept, but we're not concerned for as long as this is the first pregnancy. Why? Because in the body of Rh negative mother who has never been in contact with Rh positive blood, she simply would not have antibodies that would be working against Rh factor or D antigen. So she hasn't been sensitized yet, and therefore, even if during the labor, during delivery of a child, there is some kind of minimal penetration of fetal blood into maternal system via placenta, it won't be of any negative effect right now. But if the mom has received some red blood cells from her own baby, which were Rh positive, in the days after she delivered her child, basically her body is going to start making antibodies that are working directly against Rh antigen or D antigen. So her second pregnancy becomes a little bit more risky, because if antibodies are traveling through placenta as they're quite small in size and they can easily cross this barrier. If her second child is also Rh positive, basically a maternal owned immune system could start affecting her baby and unfortunately create a number of unwanted consequences that could be quite dramatical and sometimes even fatal for the child. So that's why it is principle of medicine that if we know that mom is Rh negative and we even assume that she gave birth to Rh positive child, assuming that this was first pregnancy, administration of drug which is called the ROGAM, that is really like form of passive immunization, will prevent formation of antibodies by maternal body itself. This passive, short-lasting immunity will wear itself out after a while, but at least second pregnancy, whether it happens year, 5 years, 7 years later, or 10 years later, is going to be without these horrible consequences. Of course, a number of other things could affect blood, whether it's some form of anemia, which could be occasionally mild, moderate, without any major problems for a person who suffers from it, to a variety of different leukemias. And we do not have time to go into these pathophysiologies and pathologies, but at least this last slide that we're using practically shows normal red blood cells, and some of them which started changing. So if we have dominance of these cells, basically we could be talking about sickle cell anemia or presence of, let's say, 50, 60, 70 or more thousand of white blood cells, quite indicative of form of leukemia. However, again, due to shortage and principal aim of these mini lectures, I really don't want to go into any more complex clinically related materials, because I believe that this goes over and above your expectations and expectations of courses that you are taking. So for now, I think that would be it. And we would have just one more topic to present in this part, is just to introduce the integumentary system, the skin. And from skin, we're going to be moving in the direction of more organ-specific anatomy and physiology, such as anatomy and physiology of respiratory tract or anatomy and physiology of digestive tract. But they're going to be a little bit more focused presentations. However, this is something that is the general denominator, something without which any studies of physiology cannot be started. I just hope that you enjoyed it. So one more about skin, and then we're moving on to something that's a little bit more tangible and perhaps much easier for me to record and for you to follow. So it's a win-win situation. Anyways, thanks for watching it. Recommend as Anatomy Made Simple by Dr. T. Some people say I retired. As you can see, I didn't retire. It's just a different form of work that I still enjoy. Have fun, stay happy, stay healthy. See you soon. Bye-bye.